Hello everyone. In this video, we'll discuss about Hodgkin's lymphoma. This video will be a short introduction towards what Hodgkin lymphoma actually is, its epidemiology, its major clinical features, how it presents, its clinical presentation, its staging, and what differentiates Hodgkin's lymphoma from non-Hodgkin's lymphoma. Why an entire category of lymphomas is called Hodgkin's, and another diverse group of lymphomas is called non-Hodgkin's lymphoma. And then in the end, we'll discuss certain MCQs that have been asked in previous years, AIMS or All India PG entrance examination. So as to give you a brief idea how to proceed with the questions. So let's begin. So as you know, lymphoma, by lymphoma we mean it's a malignant proliferation of lymphoid cells. It's a malignant proliferation of the lymphoid cells, and that's what lymphoma is. Now, with this basic knowledge of what lymphoma is, let's begin with the epidemiology of Hodgkin's lymphoma. Now, as we all know, that Hodgkin's lymphoma typically has been described to have a bimodal peak, with the first peak occurring around adolescence and the second peak occurring around after the age of 50 years. That's what has been characteristically been described. Now, we have to understand, as far as Hodgkin lymphoma is concerned, there are some differences as far as developing countries is concerned or developed nations is concerned. For example, there is a huge amount of difference as far as the epidemiology between India or US is concerned. Like I described, Hodgkin's lymphoma typically has a bimodal peak, with the first peak occurring around adolescence and the second peak occurring after 50 years of age. However, in case of a developing country like India, the first peak, the adolescence peak, tends to occur slightly before adolescence, while in the case of developed countries, the first peak tends to occur after adolescence. The second difference is as far as the gender ratio, the sex ratio is concerned, as far as Hodgkin's lymphoma is concerned. While in case of developed nations like, let's say, US, UK, the ratio is almost equal. That is, males is equal to females. Almost equally they are affected. However, in a developing nations like India, there's a much higher male preponderance. The males are affected much more as compared to female as far as Hodgkin's lymphoma is concerned. Sometimes the ratio can be as high as 4:1. Last but most importantly, in a developed nation, I'll be discussing the histological subtypes in the later video. The most common subtype is actually nodular sclerosis. This nodular sclerosis comprises around 70% of all cases of Hodgkin's lymphoma. However, that's not true in case of a developing nation, let's say like India. In a developing nation like India, mixed cellularity is much more common, is more common as compared to nodular sclerosis. So, for example, if somebody asks you, if you're appearing for USMLE and the question asks which is the most common subtype, the answer would be nodular sclerosis, because in a developed nation like US, the nodular sclerosis is the most common histological subtype. However, as far as India is concerned or any other developing nation is concerned, mixed cellularity has a much higher prevalence as compared to nodular sclerosis. Now, this is a brief discussion about the epidemiology. The few points that you should remember from epidemiology is that it's a bimodal. There is a bimodal peak. The peak differs between a developing or a developed nation, tends to occur before adolescence in a developing nation, and a developed nation it occurs after adolescence. The gender distribution is equal in the case of a developed nation, while there is a much higher males are tend to be affected much more commonly in a developing nations. This might be just be biased for that matter of fact. However, as far as the most common subtype or the histological subtype is concerned, mixed cellularity is more common as compared to nodular sclerosis in a developing nation like India, while in developed nations, nodular sclerosis is the most common subtype, accounting for around 70% of the cases. As you can see, this is just an example of this is a picture, this is an actual graph of the incidence of Hodgkin's lymphoma, and we can see that the first peak is occurring around adolescence. As you can see, the first peak is occurring around adolescence, between the age group of 15 to 25, that's around adolescence, and the second peak starts to occur after 50 years of age. So, important points to remember as far as epidemiology is concerned: bimodal in nature, male is equal to female in developed, male more than female in case of developing, and in case of, as far as histological subtype is concerned, as far as histological subtype is concerned, mixed cellularity is more common in India. Now, a brief about the presentation of is concerned. Like I said, lymphoma is nothing but a malignant proliferation of lymphoid cells. So if the lymphoid cells, your lymphoid cells are basically proliferating, what will it result in? It will result in lymphadenopathy. Because most of the time, these lymphomas will arise inside the lymph nodes. However, there can be extranodal presentation as well, because lymphatic tissue is essentially present throughout the system and lymphoid cells are present throughout the body. So, but typically, Hodgkin lymphoma is characterized by lymphadenopathy, and most commonly a progressive painless lymphadenopathy, and that is the most common presentation of Hodgkin's lymphoma. We tend to have cervical lymphadenopathy much more as compared to, let's say, mediastinal or abdominal lymphadenopathy. This is an important difference as compared to, let's say, non-Hodgkin's lymphoma. In non-Hodgkin's lymphoma, mediastinal or abdominal lymphadenopathy is more common, while in case of Hodgkin's lymphoma, you tend to have a cervical lymphadenopathy as the most common presentation of Hodgkin lymphoma. A progressive painless lymphadenopathy, your lymph nodes slowly and steadily increase inside, most commonly cervical. So typically what is presented to you as far as the case of Hodgkin lymphoma is concerned is that you will have a young male who is 15 or 16 years old and is presenting to you with 6 months history of his cervical lymph nodes typically increasing, and he was diagnosed to have, let's say, TB and then found to have actually Hodgkin's lymphoma. That's a typical presentation of Hodgkin lymphoma is concerned. Now, as we know that Hodgkin's lymphoma is a malignant proliferation of lymphoid cells, and these lymphoid cells then tend to secrete cytokines. They secrete cytokines. And these cytokines then can result in certain systemic features. Now, what are these systemic features? So this is a picture showing the typical presentation of a young male with cervical lymphadenopathy that has progressively increased and painlessly increased. Now, like I said, there is a lymphoid proliferation. It's a lymphoid cell proliferation, and these tend to secrete cytokines. And these cytokines tend to cause the systemic features. And the most common systemic features that are associated with Hodgkin lymphoma are fever, weight loss, loss of appetite, and drenching night sweats. Now, what's more important is to realize is that while these systemic symptoms can be present in any disease for that matter, any infection, HIV, tuberculosis, or other lymphomas or leukemias, these three symptoms that I just described to you right now have a particular prognostic symptoms, and these three symptoms are together known as B symptoms. These B symptoms are, first, that there is an unexplained weight loss of more than 10% over the past 6 months. There is drenching night sweats, and there's an unexplained fever of more than 101 degree Fahrenheit for more than 3 days. These three symptoms together are called the B symptoms. And it's important to recognize that these B symptoms have prognostic value. Presence of B symptoms, that is, which I first discussed, presence of night sweats, presence of weight loss, how much? More than 10% of the original weight over 6 months. And third, fever of 101 degree Fahrenheit for more than 3 days. These three symptoms in conjunction are known to have prognostic value, and they portend a poorer prognosis. And these three symptoms together are called the B symptoms. There can be other presentation of Hodgkin's lymphoma. So the presentation of Hodgkin's lymphoma that we have discussed till now is that it will present as cervical lymphadenopathy, most common lymphadenopathy, progressive painless, and whether the person can have B symptoms or do not have B symptoms. These B symptoms have a prognostic value. They portend a poorer prognosis. And these B symptoms, I'll again discuss because it's very important, are weight loss of more than 10%, presence of drenching night sweats, and last but not the least, definitely, a fever of more than 101 degree Fahrenheit for more than 3 days. Other presentation of Hodgkin's lymphoma can be the paraneoplastic syndromes that Hodgkin lymphoma has, or certain other manifestations. So the other symptoms can be the paraneoplastic symptoms. So some paraneoplastic syndrome that you might need to remember, more important if you are a postgraduate rather than an undergraduate, is the presence of nephrotic syndrome, cerebellar involvement, hypertrophic osteoarthropathy, autoimmune hemolytic anemia. Sometimes there's an extranodal spread, sometimes when the lymphatics get constricted, they can be, or when there is this lymphatic involvement involves other organs. You can have splenomegaly, hepatomegaly, pulmonary involvement, pulmonary in the formament of pleural effusion, pleurisy. You can have vertebral bone involvement if there is bony metastasis, or if there can be cutaneous involvement. These are the other sites that can be involved. But you have to remember, typically it tends to present as a cervical lymphadenopathy. And at the same point of time, you can have B symptoms because this lymph nodes, this lymphoid cells secrete cytokines and then cause these B symptoms. These B symptoms have a prognostic value. They portend a prognosis, and these B symptoms include more than 10% weight loss over past 6 months, drenching night sweats, and presence of fever for more than 3 days of more than 101 degree Fahrenheit. Now, what can be the differential diagnosis as far as Hodgkin's lymphoma is concerned? In our country, in case of India, tuberculosis and HIV, these two should always be ruled out as far as Hodgkin's lymphoma is concerned. In fact, what actually happens in our country is that most of the times a person, an adolescent male, will be coming from a TB endemic region or will have a contact history of TB and will be empirically started on ATT, thinking that the lymph node swelling and the fever the child might be having is actually TB. And when he's given 4 to 6 months of ATT and he's not responding, finally a lymph node biopsy is done, and then lymph node biopsy will show a lymphoma, will show the characteristic Reed-Steinberg cells that are present in Hodgkin's lymphoma, and that will actually establish the diagnosis as that of Hodgkin's lymphoma. HIV should always be ruled out. In fact, HIV sometimes is associated with certain subtypes of Hodgkin's lymphoma, which I'll discuss in later videos. Other common causes or rather rarer causes of lymphadenopathy should also be ruled out, such as chronic lymphoproliferative disorders, your Castleman disease, your sarcoidosis. A non-Hodgkin lymphoma should also be ruled out. A biopsy will give you obviously a clearer picture, and fungal disease like histoplasma. Now, what distinguishes Hodgkin's from non-Hodgkin lymphoma is these first two words. You have to remember these first two words. In case of non-Hodgkin lymphoma, the spread is sort of discontinuous. So you will have a lymphadenopathy here, you will have a nodal presentation, and that mass, that lymphoid neoplastic mass forms a lymph node and causes the lymph nodes to enlarge. But that's sort of haphazard. While in case of Hodgkin lymphoma, the spread is continuous and contiguous. So first you'll have, let's say, cervical lymphadenopathy. If the Hodgkin lymphoma is spreading further, then it will involve the mediastinal lymph nodes. If it's spreading further, then it will go beyond diaphragm. It will involve the aortic or the pelvic lymph nodes, and that's how Hodgkin lymphoma tends to spread. So Hodgkin lymphoma has a continuous nodal spread, a contiguous nodal spread, as compared to non-Hodgkin lymphoma, which has a discontinuous nodal spread. Then site of involvement, like I said, cervical lymphadenopathy is more common as far as Hodgkin lymphoma is concerned, but mesenteric or Waldell ring involvement is more common as far as non-Hodgkin lymphoma is concerned. Presence of B symptoms, these B symptoms, classical B symptoms, are much more common in Hodgkin's lymphoma, while they are less common as far as non-Hodgkin lymphoma is concerned. Like I said before, cervical lymphadenopathy predominates as far as Hodgkin's lymphoma is concerned, while in case of non-Hodgkin's lymphoma, abdominal lymphadenopathy predominates. So abdominal disease is much more common as far as non-Hodgkin lymphoma is concerned, while abdominal disease is less common as far as Hodgkin lymphoma is concerned. Now, non-Hodgkin lymphoma has a multiple histological subtypes, be it Burkitt lymphoma, be it mantle cell lymphoma, or follicular lymphoma, and this classification into follicular, mantle, Burkitt's, or DLBCL affects both prognosis and treatment. And so it's very important to classify whether it's DLBCL, whether it's Burkitt, whether it's mantle. But in case of Hodgkin lymphoma, while there is histological subtype grading into nodular sclerosis or mixed cellularity, but treatment is much more dependent upon staging. It's not, the subtype based treatment is not important as far as Hodgkin's lymphoma is concerned. Cure rates, Hodgkin is much more curable, with cure rates approaching more than 90%, while in case of non-Hodgkin's lymphoma, the overall cure is around 70 to 80%. We should always remember that extranodal disease is rare, CNS disease is rare, and bone marrow involvement, these three things are rare as far as Hodgkin's lymphoma is concerned, while non-Hodgkin's lymphoma, these three things are common. This might not be particularly asked in the form of an MCQ, but this is a very important question as far as your professional examination or your term examination are concerned in MBBS. Now, staging. Like I said before, Hodgkin lymphoma spreads in a contiguous manner. It spreads from one lymph node to another group of lymph node to another group of lymph nodes. It does not have a discontinuous spread. It rather has something called as contiguous spread. And more the spread, worse will be the prognosis, or more will be the staging of the disease, which will portend a poorer prognosis. And that has been modified and applied in this Ann Arbor staging. Now, what is Ann Arbor staging? Let's look into it. The Ann Arbor staging is stage 1, 2, stage 3, and stage 4. In stage 1, you will have a single, just one lymph node involvement, single lymph node involvement either above or below diaphragm. In stage 2, you will have two or more than two lymph node involvement. However, it has not crossed diaphragm. The diaphragmatic crossing is not there. Diaphragmatic crossing will signify that the disease has progressed further and will have a poorer prognosis. So you will move on to stage 3. If there is a diffuse disease that is involving liver, bone marrow, vertebral involvement, then it's stage 4. So as the spread of Hodgkin lymphoma progresses, so does the staging progresses. In stage 1, you will have a localized single lymph node or an extra lymphatic region involvement. If two or more are involved, but they are above or below the diaphragm, they have not crossed the diaphragmatic barrier, then it's called stage 2. If the diaphragmatic barrier is crossed, then it's called stage 3. If there is a widespread involvement involving liver, involving bone marrow, involving the vertebral or the cutaneous tissue, then it's stage 4. Apart from this, staging into 1, 2, 3, 4, every stage of Hodgkin lymphoma is divided into stage A or stage B. This B signifies the B symptoms that I discussed before. Like I said, B symptoms signify a poorer prognosis. So presence of B symptoms, that is drenching night sweats, your fever, your weight loss of more than 10% over 6 months, will automatically classify a disease into 2A, 2B, 1A, 1B, 3A, 3B, or 4A, 4B. So for example, a person has a single lymph node involvement above diaphragm, not crossing diaphragm, that person will call to have stage 1A1 disease. If he does not have any systemic symptom, no B symptom, then it's stage 1A. But if let's say he has B symptoms, he has fever, he has weight loss, then it will be called 1B. Apart from this, in order to define how much the disease is involving the lymph nodes, we'll have bulky disease. Again, bulky disease will signify a poorer prognosis as compared to a non-bulky disease. And this bulky disease is designated by X. Now, how do we define bulky disease? Bulky disease is defined by a nodal mass, a single node mass of more than 10 centimeter. In certain classification, in fact, ICMR uses this cutoff as 6 centimeter. In certain cases, you cannot exactly measure the nodal mass. It's not there in lymph node, it's not cervical lymph node, it's not easily measurable. If there is a radiographic assessment, then in case of, let's say, a mediastinal mass, in that, if the mediastinal mass is more than 1/3 of the total mediastinal diameter at the level of T5, T6, it's called bulky disease. So, as far as prognostication and staging of Hodgkin lymphoma is concerned, like I said, first, the staging that's done is the Ann Arbor staging. Ann Arbor staging divides it into stage 1, stage 2, stage 3, stage 4. Then further classification into A or B or bulky disease. Apart from this also, there are certain whether the extranodal disease is involved. Then if extranodal disease is involved, then we'll call it E. If it's not, then we do not give any suffix. And along with this, if spleen is involved, then we give the suffix of S. Now let's do a small quiz as far as this staging of Ann Arbor staging of Hodgkin lymphoma is concerned. Let's assume you have an asymptomatic patient with bilateral cervical and right axillary lymph node involvement. Now, more than 2, so it automatically becomes stage 2. It's not crossing diaphragm. Axilla and cervical both are present above diaphragm. So, not crossing diaphragm. So, it does not become stage 3. So, it's stage 2. The patient is asymptomatic. He does not have B symptoms. So, it is stage 2A. Spleen is not involved. So, it's not, S won't be there as a suffix. It's not a bulky disease. It has not been said so in the presentation. So, X won't be there. So, this patient will become stage 2A. Now, let's assume we have another patient. This patient has drenching night sweat, weight loss. So, he has B symptoms. He has cervical lymph node involvement, he has aortic lymph node involvement, he has pelvic lymph node involvement. So more than 2 groups of, so it becomes more than stage 2. They are crossing the diaphragm because pelvic lymph nodes are present below diaphragm, cervical lymph nodes are present above diaphragm. So it becomes stage 3. Since B symptoms are there, it becomes stage 3B. And if you look closely at this presentation says that he has a 10 centimeter mediastinal mass. So it also becomes bulky disease designated as 3BX. So by this definition, by Ann Arbor staging, this patient will have stage 3BX disease. It specifically says that there is no liver or marrow involvement. If there was liver and marrow involvement, it would have become stage 4 according to the Ann Arbor staging. So we have done a brief overview as far as the epidemiology, the normal clinical presentation, features and staging is done. Let's discuss some questions that have been asked in previous year postgraduate entrance examination. Question is, which disease is characterized by a stepwise progression and spread, hence staging is an important prognostic factor. So as we are discussing, it's Hodgkin's lymphoma. The answer here is Hodgkin's lymphoma. Hodgkin lymphoma is classically described to have a contiguous spread, and this is why it has staging was also defined or discussed or is made according to the spread, and Hodgkin lymphoma is the correct answer as far as this question is concerned. Pale type of fever is seen as since we are discussing Hodgkin lymphoma, the answer is Hodgkin lymphoma. So we discussed that B symptoms, we discussed that there should be fever for more than 101 degree Fahrenheit for more than 3 days. Now what is Pale type of fever? This Pale type of fever is the characteristic fever of Hodgkin lymphoma, in which what happens is that you will have fever for 7 to 10 days, and then there will be no fever for 7 to 10 days, and then again you will have a continuous ride for 7 to 10 days. This pattern of fever is called Pell-Epstein fever, and this is typically and classically seen in Hodgkin's lymphoma. So answer here becomes Hodgkin's lymphoma. Pell-Epstein type of fever is seen in Hodgkin's lymphoma. There are other options can easily be ruled out. In typhoid, what we typically see is a stepladder pattern of fever. In non-Hodgkin's, there will be continuous fever. Pell-Epstein fever is not seen. In dengue, will have fever with a lot of myalgia and arthritis, which won't be seen as far as this Pell-Epstein fever won't be seen. Now, most common subtype of Hodgkin lymphoma in India. So this is an important question, and this is how the examiner might confuse us. If the examiner would have simply asked most common subtype of Hodgkin lymphoma, the answer would be nodular sclerosis. However, since the examiner asked in India, and like I discussed before in the epidemiology, in a developing nation like India, the most common subtype is mixed cellularity. So in this scenario, the actual correct answer is mixed cellularity. If India was not mentioned, then the actual answer would have been nodular sclerosis. Thank you. This was a brief intro into the epidemiology, the clinical features, the staging of Hodgkin lymphoma. Hope you liked the video. Please like, share and subscribe if you want to watch further similar content. Thank you.